chairs. No walk-in appointments. There we go. Hello, everyone. You all know me as Catherine Fitch Smith. Today we are here, obviously, for my thesis defense, making health literacy accessible, a content analysis of the CDC's health literacy web pages. Obviously, very excited to be here. Just a little nervous, but very excited because finally someone's requiring me to sit down and really, really get into this. So I'm just exhausted. I know I am.
Exhausted.
Yes, yes, 100%. Health literacy is one's ability to access, understand, and use health information and services to make an informed decision. Organizations play a crucial role in health literacy because they're the ones providing us this information and services that we rely on. When we go to a doctor or when we need any kind of health intervention, we're going to a doctor's office, a clinic, maybe a health department, maybe a resource center, all of these places, right, to seek care. Local organizations, like the ones that we visit frequently, depend on national or global guidance to improve their communication strategies around health. Here enters health literacy. This study explores the emergent themes occurring at the national level in the CDC's health literacy guidelines that can be used to develop guidance for health literacy communication materials at the local level. Leaders in health literacy recognize the gap between national health literacy guidance and local application, and all support the need for health literacy communication guidance that provides recommendations for local contexts. They also recognize that smaller organizations have a much better ability to reach their audiences much closer because they're local. Thus, the question this research seeks to answer, first, very loaded, long question, okay? Are there emergent themes occurring at the national level and the Center for Disease Control's health literacy guidelines that can be used to develop guidance for health literacy communication materials at the local level? And second, are the health literacy guidelines on the CDC's health literacy web pages clear and actionable enough to be adapted at the local grassroots level? So first, I'll provide a brief background about why I've chosen this topic, what the literature has to say about it, the methods and results, and then a lot to discuss about those. And then I'm saving my future recommendations, limitations, and my acknowledgements for the end. There are a few reasons why I chose to really dig into health literacy. So let me tell you a little story while we have the time. As most of you here know, throughout my childhood, I had a pretty hard time in school. There were often times where I would sit with a tutor and we would just go over the same concepts over and over again. And when I would be asked to repeat these concepts, I would blank. I just had no idea. I would just totally blank. I would understand the words that were being said, but not the meaning of them. And then I just couldn't remember a thing. It brought on a lot of guilt for wasting the person's time, a lot of shame because, well, why couldn't I just understand? And at times, feelings of complete incompetence. It became very clear that I was behind my peers and also very embarrassing if I didn't know what was going on, because even if I had the courage to ask a question in front of my peers, I often just didn't even have the words or the vocabulary or terms to use to really just know what I was talking about. And then I would just confuse myself and sometimes the teacher. Around this time is ironically when I stumbled on the term health communication, but it wasn't until much later that I came across the term health literacy. Those feelings that I mentioned earlier about feeling shame for not comprehending information or guilt that I was wasting someone's time or thoughts that I had no idea what was being said and I probably never would, or just not even having those words to ask questions back to a teacher, or in our case, a healthcare provider. Those are some of the same feelings that keep people from achieving optimal health, which is considered health equity, but social determinants of health and health disparities and the ability to even access health information and services is obviously a huge barrier. My job as a health communicator in this space then is to be the one that reaches the person and that gives them the meaning in a way that they can use and understand and make a choice based on that, right? And it's an organization's role, whether large or small. This brings me to October 2023, just last year. I was making some like great, October is Health Literacy Awareness Month. So I was making some great communication materials for it, which some of them are actually right here. And as I was like researching, I just kept thinking like, but what's the punchline here? Like, what am I telling people to do? All I could tell them was to learn more, visit, and just put a link there to the CDC's health literacy guidelines. And the important thing that I just kept thinking about is like increasing health literacy just isn't as tangible as something like bettering mental health. Like if I want to better my mental health, I can spend more time outside, go on a walk, I can journal, I can, practice better boundaries or something. But for health literacy and your level of proficiency, or ability to even increase it takes time and is often a result of your environment and the kinds of health information or services you can even access in the first place. For people like myself wanting to increase health literacy in my community, the first place we go are to national or global leaders in this area, right? So like the CDC. So without further ado, let's see what the literature has to say about it. There are a few things worth mentioning very plainly that I've already kind of mentioned. Any conversation about health literacy often has health equity and health disparities inside the conversation. Health equity, the ability for everyone to have a fair opportunity to attain their highest level of health, and health disparities are the conditions in one's environment known as social determinants of health that affect health, functioning, quality of life, outcomes, and risks. Now, let me also clarify, two forms of health literacy: personal, it's your ability to find, use, and access health information and services and make informed choices for your health that better them. And then organizational is my ability to provide you that as an organization. Speaking of organizations, the World Health Organization emphasizes, that health literacy is an evolving concept. They were right. They were right about that. It's always evolving, right? And now it's seen more now than just being able to read a pamphlet or follow like medicine bottle directions. Modern approaches prioritize putting a patient first. A patient with basic or proficient health literacy can comprehend, recall, and apply health information to make an informed choice. For patients with below basic health literacy levels, pairing written information with a visual like an illustration and even offering some kind of interactive conversation is the best opportunity for them to attain a higher level of health literacy or health. It's more than your ability to do something, it's your ability to meaningfully interact with that information to better your health. So what have the national organizations done? Or maybe even the global? Globally, again, the World Health Organization, they've been involved with health literacy for a very, very long time. But here in the US, government initiatives initially focused on school-based programs. And then they decided, oh, we're starting to see a lot of changes in health literacy. Adults in America are really not doing great. So they pivoted. So notable policies include the Affordable Care Act, which highlighted the financial burden that patients with low health literacy cause on the health system. So just think about the financial burden. Oh, terrible. Playwriting Act of 2010 aimed at improving the effectiveness and accountability of federal agencies to the public by promoting clear governmental communication. HHS also developed the National Action Plan to improve health literacy, which the CDC mentions a lot, and I'll get to that later. But while many policies and initiatives mention health literacy, few focus on very key communication elements that health information or services can become accessible by. So another few key parts of the conversation. Plain language ensures clear communication. It focuses on key messages. It organizes information, with a bulleted list. It kind of just separates it out, avoids medical jargon, of course. 508 compliance, a part of the Rehabilitation Act of 1973, ensures that federal agencies abide by digital accessibility standards. So it means if you go on a government website, it means you can easily navigate it. It means that the text, color contrast ratios are correct, so it's readable. And if you have like an illustration or a picture, it means that if I were to use a screen reader, I have alt text with the image, so everything on the website or any digital government content is accessible by anyone, right? User-centered design is kind of similar. It's a form of design that really puts the user first. It asks, what am I making? Who is the audience? What's the end result there? So it's every aspect of design, but it's not just like graphic design. It's like, who's using this? How can I make this usable for them? Patient-centered care focuses on integrating patient perspectives and preferences, prioritizing their needs over the provider's viewpoint. And the culture-centered approach is the acknowledgement that health interactions involve the negotiation of shared meanings embedded in socially constructed identities, relationships, social norms, and they're all mutually interdependent. All of this background informed the methods to examine whether emergent themes in the CDC's health literacy guidelines can inform actionable local guidance. A content analysis was conducted. 2 primary coding categories emerged: the CDC's characterization of health literacy and its association with accessibility. And if anyone has questions about the table with like the big pages and the subpages of the content, I have that at the end. And then I have definitions here of these codes. So for the results, the content analysis showed that health literacy is characterized by bureaucratic speech, recursive language, active voice, and objective language. And then for the second category, factors associated with accessibility, there were occurrences of plain language, 508 compliance, patient-centered care, culture-centered approach, and finally, user-centered design. From the literature review and content analysis, I started really wondering what the role that national organizations play in all of this. Are they a starting point? Like, who's the middleman here that's operationalizing all of this guidance? I don't have an answer for that, at least not yet. But let's start with the CDC's characterization of health literacy. First up, bureaucratic speech with 79 occurrences. It's characterized by jargon, complex words, euphemisms, or buzzwords, common in formal governmental communication. Kadarisman describes this style as one that puts policy and law before the audience's needs. And with 48% of American adults having basic or below basic health literacy skills, this language poses a very significant barrier to comprehension. Key point in health literacy, gotta comprehend. Complex messages are harder to recall and act on. In terms like calling the National Action Plan for Health Literacy a blueprint over and over throughout the content, it kind of just creates a disconnect between the audience and the content's intents, and it just highlights an ongoing struggle to make health information truly accessible. This brings me to recursive language. Identified 133 times, it involves repeated grammatical structures. In healthcare, there's a thing called the recursive frame analysis. It's a therapeutic model, and it can be really helpful for like reinforcing key ideas, really going over a narrative. And it can be, again, like it's used in healthcare, it's really great, but while repetition, yeah, it can support health literacy by reinforcing key ideas. Overuse just risks redundancy, filler content, and causes disengagement with the audience. And for health professionals, like, yeah, it can reinforce key ideas. That's great. If they're already familiar with this terminology, it will reinforce things. But if they're not, again, it's just a disconnect. And for individuals with basic or below basic health literacy, excessive repetition can cause frustration and overwhelming cognitive load, and it hinders comprehension. While bureaucratic speech and recursive language can create challenges for the audience, the CDC's health literacy web pages did have 210 occurrences of active voice and 98 occurrences of objective language, which do help reduce confusion. Active voice clarifies who is performing an act at the beginning of the sentence, while objective language presents facts up front. To the point, this is fact. Both of these are important in, reinforcing trust and clarity, and not to bring up the pandemic, but we know that took a big public trust hit. And for both, patients wanting to learn about health literacy, but also health professionals that want trusted information because they're bringing it to their community. These are great. Active voice is great, and objective language, again, those facts, like rest in the facts. Now are factors associated with accessibility. plain language, 74 occurrences is a critical factor in accessibility. It avoids jargon also and prioritizes audience's needs, making communication, of course, easier to understand and use. But it's not the watering down of information, nor is it the dumbing down of information. Plain language just gets to the point. 508 compliance occurred only 23 times and was not mentioned explicitly at all, the term itself, and I'll come back to that especially. But so 23 times, yeah, it was represented. And that's obviously another essential piece for ensuring digital accessibility. And I hope I'm allowed to say this, but I will say, I was a little bit surprised that certain accessibility factors weren't mentioned more throughout the content, or at least like dispersed throughout. They were contained to certain sections. It's not an opinion, it's a fact. Can I say patient-centered care occurred 125 times in the content, and this approach again encourages patients to play an active role in their care. However, when you're mixing a positive thing like patient-centered care with that many occurrences, with something like, bureaucratic speech, the tension between some of these really positive elements like patient-centered care, and then, I don't want to call bureaucratic speech necessarily negative, it kind of creates a gap when you're addressing populations like these and also culturally diverse populations too. Which that brings me to culture-centered approach with 67 occurrences. Dutta, the creator of this approach, highlights that culture shapes our perception of health, our perception of illness, our perception of our health outcomes, and in the messages, the meanings in the message, our perception is shaped. And while the CDC recognizes that culture matters, it matters in communication planning, talking about really putting it into strategy and really the importance of it, it wasn't really acknowledged that much. And so, again, like there's a difference between giving someone a definition and then providing that meaning to it. Speaking also of tailoring to audiences, user-centered design had 25 occurrences. It ensures health information and services can be used by the intended audience. And while the CDC does include this concept on the web pages, the term is only mentioned once explicitly and implicitly the other mentions. For health communicators at the local level who are already juggling various roles, these principles are essential to really place emphasis on, and resources that explain this concept are sufficient, but it brings me to just a little tangent, just a little. When you read through the thesis, you'll see that I'm mentioning a lot. There were this amount of explicit mentions and this amount of implicit mentions, and it kind of goes back to the story at the beginning where I'm like, I didn't really have the terms. And looking through the content, 508 compliance, that term was not mentioned at all. It was implicit, but I know that because I know what 508 compliance is. And so for user-centered design, only mentioned once explicitly, user-centered design, I can see that there are all these other mentions of it because I know what the concept is. So for people that are coming here, like health professionals wanting to learn more, they can't ascribe importance to different parts when they aren't aware of them. And so for the CDC, who's showing you all of this content and they're not really drawing you to exactly what matters, and if you want to do some Googling or if you want to get some training, you need to have these very clear, explicit terms to use to learn more about them when we go to Google, right? So I just had to say that, okay? All in all, the content analysis revealed that while the CDC's health literacy web pages are a very valuable resource for health professionals and individuals looking to improve their health literacy, local grassroots organizations and health departments with limited resources, funding, and time may struggle to operationalize this guidance. The CDC's web pages are like a library full of very useful links, but the time required to navigate and understand the material enough to adapt it into strategy at the local level, it might just be a little bit too much for smaller organizations. And this raises that question again, like, okay, if national organizations create a starting point, who's the one operationalizing it? And that's just not defined anywhere. And I think that these are fair questions because as much as I felt the content analysis was thorough, there are still limitations. Segue. That was good. So the study employed quantitative content analysis, which means there is a subjective element to it. And to represent specific concepts that have been found meaningful by myself, obviously subjective, right? But there was an intercoder reliability score of 84.25%, but unconscious bias does remain a potential limitation as much as I very painfully tried to avoid it. So allow me to make some suggestions for future research. While both national and local organizations have made progress in raising awareness about health literacy and the need for better communication guidance in this area, the operationalizing of this guidance has yet to be studied widely. In order to strengthen the research design of this study, a mixed methods approach would be great. Combining content analysis and interviews or focus groups could reveal themes that have yet to be identified throughout this study. And future research is also recommended to focus on the factors in communication that make guidance operational. What are these mechanisms that make something, the ability to be operationalized in any way? Well, we have covered a lot of ground here today. And as you all know, this study has been born from a very deep desire to understand health literacy and how health communication professionals with varied abilities, knowledge, and resources can best adjust the communication guidance to meet the needs of all communities, right? And the CDC health literacy web pages do a great job at breaking the ice, but I think there's still more that needs to be done, right? There always is, okay? For lack of a better way to end this, I'm ready to make a few acknowledgements. Dr. Shores, well, first of all, to my family who's on Zoom or will watch the recording, I love you all, thank you all. I'll write you all letters for Christmas. I have it all planned out, fuzzy socks and all, and then here's my thesis and a letter. It's gonna be great. And then to Dr. Shores for everything. I cannot put it into words. You know my heart, all of you do. To everyone in this room, seriously, Dr. Wold, PhD Dr. Wold, who has his PhD. If Cindy was interacting, she would, but to you, I'm glad you're here too. Thank you for being a part of this. And then Dr. Jones, you were the first person to let me, I just did the little basic highlighting, coding, whatever. So thank you for that. And then to my husband, Tyler, for letting me be so intense about all of this for so long and for loving me anyway, for just loving me anyway. And I think so now this is, wait for it, mock-up. Those are my sources. You have them anyway already in my actual thesis, but why not do a mock-up? Boom.
That's great.
So that's that.
Yeah. Good job. So articulate. So questions about our research or
Ready.
Comments or just wanting to know more?
I want to know more about the scandal. So you said
Mhm.
you didn't know if you could bring it up, and talking about the 508, there are certain things that aren't, but you never mentioned what those certain things
Okay,
are.
so the scandal is me. I am, because Dr. Shores is really good at reminding me to rein it in. It's unbiased. I need to be unbiased. So if you're not, I don't know if you know this. So my background, I started my career at a health department in Richmond, Virginia. My mom went to Regent. But anyway, all this to say, for me, looking at like what national leaders do from a local perspective, there were a lot of times where I was like, okay, like you don't need a degree to do what you do at a health department, like for communication campaigns, but like there was just such a large disconnect. And I'm going to be honest, like I would look at this guidance and say, you're just telling everyone that you do all this stuff, but you don't like, oh, we're funding this, we're researching this, we're doing this. And I'm like, but, and I kept thinking about, we had, in Richmond, we have a bunch of resource centers. So like a lot of community health workers that are totally on the ground level. And I'm like, if I was one of them, like originally when I started this thesis, I was like, if I was one of them in a community like health organization, like whatever resource center, I'm in the projects, like, am I going to know? Like, am I going to know to look? So for me, in my role, what I did basically was from Asbury, learned how to design, I learned how to illustrate, I learned how to communicate, and I just brought it all together. So I would do a lot of our campaigns. And I just kept thinking like, like if they wanted to do that in the communities that they're in, how would they do that? Because it goes back to like mental health, like so popular, like to be on social media and be like, ooh, look, this is a mental health hack. And there's just not those tangible answers for health literacy. And it really is about like where you can access health anything. And if you know, I mean, not doctors are amazing. I'm not saying anything like if your doctor just uses medical jargon, but like when you're not given the tools to really learn and increase your health literacy, if you don't have access to information or services, and if these organizations, big and small, can't provide you those things, there's just such a large gap from we're doing all this amazing stuff and we're struggling here at the bottom. We don't have funding. We can't do these things even if we wanted to. And then you run into like policy, like some of their suggestions were like, oh, well, you can create a new policy at your organization. And it's like, if I'm at a health department and I have to deal with the state to be able to change some kind of policy, that's not going to happen. Hello. Do you have any questions?
You got here as quickly as you could.
Are amazing.
I hope you didn't
I hope
get-
you wrote some questions on the plane.
I took screenshots on my phone.
Yes.
of Pages.
Oh, good. Okay, good. I'm ready. I'm ready for him. That was a good question. Even though it's not as dramatic, I guess. It's just a little bit.
There were a few moments where I was like, Catherine, I see you on the hill with a cape, arms akimbo, you're doing this, and I'm like,
Literally.
you really have to.
Yeah, you gotta do it.
You gotta do the work
Yeah.
to prove that you can do that, you know.
I was like a vigilante, like
Yeah.
ready to, you know.
Yeah, so the null hypothesis came up a couple of times.
Yeah, yeah. Literally. Thank you to you because I'm like, and also like throughout, I just kept getting confused about certain things. So I kept having to have you repeat them. And I'm like, but you did it in a way that I actually could understand. So like first time for that was great. But yeah, please ask me questions.
One of the things that I don't know if came through, but you know, she did all of the CDC
Oh,
health literacy web pages. So it truly is quantitative in that respect, you know, like she covered the whole thing. And then to get that agreement for 20% of it chosen at random was a significant thing, you know. And there was some going back and forth and some just,
Yeah.
which is, you know, allowed in terms of like, when I say this, what do you mean? What do you know, just kind of bringing your inner coder up to speed on what you mean by these terms, these codes. But painstakingly went over this in terms of emergent themes. And so that I was really proud of her for that, of just like reading and tweaking the themes, you know, that were emerging codes, and kind of whittling them down. You know.
thank you for saying that.
Yeah.
I made a whole like mind map where I like had a million different terms and then cut them out and then just put them on the floor.
Mm-hmm.
And then my dog, Ladybird, kept running through them. Then it would get all messed up. And I was like, oh, why? I appreciate you saying that. And I think actually for the intercoder thing too, it kind of goes back to like the explicit versus implicit mentions where I'm like, I could see, you know, in bulk some of these terms because I understood them at a certain depth enough to be like, oh, that's patient-centered care. And so I guess, yeah, for the intercoder part too, that was like an element of like, it's not all explicit, some of it's implied and yeah.
How do you recognize?
Yeah.
All that I was as I was reading through it, I slowly was starting to realize how much you had to cover. I was thinking like, oh, there's a page.
101
There's a
PDF
page
pages.
on the,
Thank
on
you.
the CDC website that you looked at.
Oh.
This is like a huge government documents.
Thank you for
That
saying
was
that.
very.
Yeah, she brought she printed the whole thing out.
Oh, yeah, I
They were
did.
to
Oh, yeah.
James.
I'm gonna save it for the rest of my life. My mom's gonna tell me to throw it out, but I can't. It's like, it's thick, like, and it's all small, and so I just highlighted and got a pen and just more than once. But yeah, I appreciate y'all saying that.
Were there surprises for you? Where you were ready to go in, like this to the CDC and you're like, okay, actually.
Mhm.
Like-
Yeah.
Like what were some of the places where you actually found evidence that they were doing things well, or at least trying? I mean, you had some of that up there.
God is a merciful God. I'm going to start with that because I was in the beginning very much like, you need to do this, you need to do that. But I think throughout the content, I had to obviously take a step back. I'm admitting it. I took a step back. And I think I just had to realize like, okay, like they're still doing their job. They're still providing us resources. Yeah, it takes time. Yeah, we don't all have a lot of funding, blah, blah. But like they still have a starting point and such an amazing mass of information. Links to free, like so many free courses, so many free trainings. And like for that, I'm like, you know what? That's great. Like that especially. And I think like as far as like any big things I really realized was that like explicit versus implicit, but also being able to be like, oh, if I'm a health professional, unfamiliar with all of this, like looking through that lens, and there are certain things that haven't had more emphasis placed on, those were kind of important things. Like, and so I know, like, again, like I'm the one that's ascribing meaning to all these elements and these things, but so I think in many ways I was like, okay, CDC, you did a good job. Like that's fine. You do a great job. You have a lot of resources. But yeah, I think there was like, that was the big, like maybe epiphany is like, you don't have the words, you don't know how to keep looking up certain terms, to keep learning about them. I think, yeah, that was really, because I kept saying explicit versus implicit, like throughout all that content. And I'm like, why I feel the need to mention this because it matters. And then finally it was that big like exclamation point of like, oh wait, yes, it matters. But again, yeah.
I think the story you told at the beginning of your own journey,
it's true,
really makes it pop. As far as if you don't have the words, you can't recognize the implicit if you don't have the explicit. Questions or?
Yeah, you kind of, did this study, it's like an audit of what they have out there for local health organizations to use as a resource. I'm wondering if maybe not actually, drilling down into section 9 there, but it's almost like one of the things they could do is recommend an audit of all of the program information at the local level.
Yes.
Recommended, things to look for. Do you have this? Do you not have
Yeah.
this? That kind of thing.
So they have a little bit of that.
Okay.
And actually, I don't know which section it was. This kind of goes hand in hand with that. So they had like evaluate your program. So like once you have programs built, yeah, like kind of like an audit, do things like that. But they also had make your own plan. Do you remember that? Yeah. It was like it had a bunch of like blank sections that it's a little worksheet, you can write things out, but then like some of even the headers are like questions you're supposed to ask yourself at your smaller organization just were like not connecting, and they weren't like like again, like I would look at it and be like, I know what you're saying, but like if someone just prints this out and then just starts like writing things in it, it just was like, oh, make your plan, like it just didn't connect. And anyway, so they did have like some of that, and like the evaluating your programs part actually was good. That was very helpful, and it was almost like an audit, like go through them. And then they talked a little bit, which is where some of the user-centered design things were, I guess, occurred. They talked a little bit about not just like obviously designing for the user, but also like testing it and going over your materials and testing them on audiences, which obviously with user-centered design, you do, tests, like you do test it throughout, or best practices, you test on your audience throughout the process. And then you like get the better product, right? And yeah, so they yes, I'll give them that. They did tell us to audit, but then you need someone to like go through it. And that's the other. That would have been me. I don't mind doing that.
So if the CDC hired you tomorrow, like you're like, read this thesis
Yeah.
and then hire me, what would you do to make it better?
I would start with the pages that obviously this sounds so whatever. Start with what needs the most work. I think like the repetitive nature of all of it was bringing in just the same copy over and over again, which made sense. Like, oh, I could be going to like a page section 9 without going to section 1. And so like you do need that consistency throughout saying like what health literacy is, like that makes total sense. But I think there are sections like the make your own plan. Actually, that might be where I start, because like while I'm refining the rest of the website and figuring out that content, if I can just really quick make a little bit better of a plan or a template or something like that, to me personally would be the easiest thing for me to do quickly. And I hate to say quickly because, but I'd probably just start with that, because if in the meantime, as I'm going over all the other content, if in the meantime, people visiting that make your plan part can be making their plans in an actual actionable way, it would kind of like save some time in the overall span of things, because organizations can start planning for real, and then I can do all the other stuff in the background. That's yeah, I hadn't thought about that.
Well,
Hello.
I'm sure we have.
Yeah,
We had a couple classes.
yeah,
I don't know how often we've been in person.
yeah, yeah.
So I've just been mapping out, trying to figure out what my thoughts are, and I think I've distilled it into
Yes,
not pages and pages.
same.
But, I kind of had a couple matrix moments.
Yes.
Like listening to you. I was like, I realized how much that my received wisdom that I've just gotten from osmosis about health has structured my life.
Yes,
Like I work out in the morning, and
yes,
that's a cultural practice that's the origins. I do
Boom.
cardio, which has origins in like a book and like
Yes.
60s, and it's like
so
it's like
true.
I'm realizing,
Mhm.
like seeing the forest for the trees or vice versa, like all these practices
Yep.
that I do or don't do or judge myself for not doing. or
Yeah,
think
right,
doing,
yeah.
like,
Yeah,
the way that this knowledge has structured my life. So that's
yes.
thank you for like prompting that light bulb moment. That was
Oh, it's so true though. It's all influenced. It's culture, it's social norms, it's just all, and that's communication, which all of you have taught a different piece, but they all come together. So beautiful. Stop. No, keep going. But yeah, please, if you have a question, absolutely. That's so cool.
and then I think there's a second main idea.
Mhm.
So the first one was the light bulb. Thank you for that.
Love.
The second one was I really do kind of get that you were talking about seeing scandals or seeing like imperfections or whatever, and I think I understand and feel the same kind of holding no,
Yeah.
like something is wrong, something should be fixed,
Yes.
kind of thing.
Yes.
But your diligence and working and actually doing the it's
Yeah.
I want to grow into this kind of person who can hold my no and do the work.
Yes.
And thank you for as somebody who's a few years
Yeah.
further in the programs and
Yes.
whatever.
You'll find it.
I guess I would like to thank you for modeling that role.
Yeah. Oh, thank you for saying that. I really appreciate that. Woohoo! It does. I'm telling you, it's over time, but then you start to find what your specialties are. And then sophomore year, I did research with her, and I also had a bunch of classes with y'all. And then culture stuff started maybe early junior year, maybe late sophomore year. And so all these ideas were coming together at the same time. And I had already I have both medicine and public health in my family. And also my granddad started an organization in Richmond, basically, that provides, low cost healthcare, things like that. And so I grew up around some of this stuff, but being able to, I didn't think I could ever, I was like, oh, I want to be a doctor, but I didn't I just couldn't, my brain doesn't work that way. Like I just couldn't connect those dots.
Mm.
And maybe I could now, I don't know, but I don't know if I can, but I like this much more. Like I think I found my area, and I think like you just like over time, just from all of them, like talking to them, like having all of them mentor you at the same time, I felt like that. And all the, like, I felt, you know, first, for the really the first time in my life, I felt understood by all of you.
Here, smile. I always forget
He's taking a
to.
selfie. Don't
It's just really good.
Oh, I don't know if my mom's on. She's done that before. Or a FaceTime. How do I turn the camera? Oh, that was good. Which actually at the end, I'd like to get pictures of all of us.
Yeah,
together.
yeah, just don't let us forget.
But still, any questions? I'm here for it. We've worked so hard.
Yeah.
Yes.
So after you take a much needed rest.
Yes.
And celebrate Christmas and graduation and all the
Yeah.
things. Do you have plans for this specific study? Do you hope to present it? Or
I'm hoping to hopefully publish.
Mhm.
I'd like to really like the operationalizing side of that and like what makes things operational. I'd like to look at that more. I hope someone gets on me, even though I'm not still in school after all this, be like, Catherine, have you been working on that? But yeah, I would like to publish. Yeah, I would love to, absolutely. Condense it all into a little article.
I think it's really important in the
Mhm.
evaluation, so.
If you have anything too that you need a little extra person on, or even just coding stuff, just
Well,
let
I
me
was
know.
thinking just writing this up into creating a presentation off of this. I mean, you've already got one right here. We could tweak it some. But then turning this into an article
Mhm.
is important, is a very important next step. This needs to be shared. And I think that your idea, she was originally talking about interviewing, there's 6
Resource center, yeah,
resource
7.
center, 7
Mhm.
in Richmond, and she was actually going to interview these leaders after they encountered, dealt with the CDC website to talk to them about what the roadblocks were. And I think, triangulating this resource with that would be huge.
Oh, it'd be so nice.
Boots on the ground, somebody being like,
Mhm.
where did you get stuck? What don't
Mhm.
you understand? What frustrates you would be huge.
Oh my gosh, yeah, from
Mhm.
all the levels, like from community health workers, but then the leaders of like, I mean, at least Richmond City Health
Mhm.
District, if not, I could get a few mediation people involved, that would be
Mhm.
fun, but
Mhm.
that'd be cool, because there's a huge gap. Even from community health worker to like the health director, like, so I would say like, so I was on the communications team and we were very close to the community health workers in the resource centers. We were really tapped into that, but like our leadership currently is great. I'm not saying anything bad, but there's just no connect there. So like if we weren't as a team trying to be like, we love the resource centers, let's do everything we possibly can to make all this accessible, there would be no one, maybe there'd be someone holding it us to it, but there's just so much more of like a connection now than there was. But
Mhm.
and that, like, again, a communications team at a local level is not traditional at all. I mean, it really, like, after or the start of COVID, that's when we kind of solidified a team and then kept going. But then like funding, like that was another, issue of why people jumped in and out. And so, yeah, anyway, but yeah,
Mhm.
I'd love to do that.
Mhm.
It'd be crazy.
Or just send
Crazy.
this to the head of the CDC with a front page that says, hire me.
I know. I'm gonna keep it in my just in case.